So today we are going to do clinical cases for MRCPCH, FOP, Foundation of Practice. That is, we are going to do some cases. Okay, some cases from Foundation of Practice. Actually, in my regular batch, we are doing now GIT. So I thought of taking the clinical cases of GIT, not all cases because it requires a lot of time. Maybe few cases we'll do from GIT. So we have from GIT. Let me show you how to find the clinical cases of only GIT. Just give me 2 minutes. I've been showing this in almost all my live classes and also sometimes in my regular batch class with a lot of questions from this topic. Yeah. Yeah. Okay, I got it. Can you guys see this chart? I think almost everybody has this chart. I have shared this chart on my Facebook group. I have shared this on my WhatsApp group and also in the videos. So for GIT and hepato, from the FOP, we have 15, 18, 37, 46, and also case number 50. Okay, it is actually part of GIT because it is from nutrition. So since we are not doing hepato, we'll be only doing some of the GIT cases today. Now let us go back to again the clinical cases book. It's the clinical cases FOP book. We have case number 15, 18, 36, 37, and 46, 50. So among that, one of the cases where case number 46 we discussed in my last live class. I think it was a discussion about just MRCPCH. So somebody requested me to complete the case because I actually just read a first case to show that how usually you have to solve the clinical cases. So we'll be solving case number 46 first, and then that is case number 46, and then we'll go back to other cases. Okay, so case number 46, 209. This is still 44. Go to case number 46. So clinical cases FOP, it is not only important for foundation of practice FOP exam, it is also a part of AKP if you're going for the part 2 exam. In AKP cases, almost 1/3 of the portions are from clinical cases of FOP and FOP. You can't hear me? Can you guys hear me?
Yes.
Yes.
Okay, Dr.
Yes.
Dr. Sadaf, maybe you need to just adjust the microphone or something. Okay, so even if you are preparing for AKP, whatever it is, about 1/3 of the portion will be from foundation of practice. So clinical cases, and when I was preparing for AKP, I found more than the clinical cases of AKP, I found the clinical cases of FOP were very, very good. You could correlate if you are studying 2-3 cases and you're going through the system, you will be able to correlate, you will be able to, have a picture in your mind about that particular system. So please mute yourself. It is Shiana. Okay. I'm muting anybody. If you're only for discussing, like if you want to say something, then you can unmute. Otherwise, please kindly mute yourself. Okay. So we'll start with this case. It is known as Melena Monday. So what do we have here? You are the gastroenterology ST2 doctor working in the local children hospital. The emergency department refer the following children to you on Monday. So we have here certain cases, and then we are given the following are a list of investigation. So we have, this is basically an EMQ. In exam, FOP and task both will have about 6 EMQs, and the rest of them are best of 5. So this is the format of EMQ. That will be given about 9 to 10 options, and then you will be given some scenarios. You have to match the option with the scenario. Okay. So these are the investigation and these are the scenarios. What is the most appropriate diagnostic investigation? So let us go through our first case. What they're saying: a 16-month-old girl presents with a history of melena for the last few days. Her mother says she seemed to have had tummy pain in the morning, but is better when she has eaten. She fractured her legs 2 weeks ago when she fell down the stairs, and her leg remains in a plaster cast. She is otherwise well. Okay, she's good. Her mother has been given her medicine to help the pain. So whenever you read a scenario, first things is that you have to understand that definitely, since it is not, this is not practical, this is theoretical exam. So obviously they're going to give you certain clues. Okay, they're going to give you certain clues, they're going to give you something to pick up. Now your duty is to look for the clues. Okay, and you must know how to find the clues. First of all, since we are studying GIT, okay, these are, we'll be doing all the cases of some cases of GIT today, not all the cases. So you have to remember what are the commonest causes of GIT, that is gastrointestinal disorders, in pediatric population. Okay, depending on that, you have to keep everything in mind. So we have a 16-month-old girl. Okay, first option is the age. Second one is melena. What is melena?
Passage of black stool.
Okay, so if there is melena, see, a child has melena. So what does it signify basically? See, whenever there is, so I'm just drawing a very rough diagram, and let's, the screen is visible to you guys, the whiteboard.
Yes.
Okay, thank you. So I'm just drawing a very rough diagram. Okay, and consider this the upper GIT. Okay, upper portion of the GIT. And consider, suppose, the duodenum, up to the duodenum, or maybe early part of the proximal part of the jejunum. And then from the jejunum, the distal part of the jejunum and whole of the large intestine, consider this as the lower GIT, for example. So if there is bleeding from the upper GIT, by the time the blood reaches the lower GIT and it is excreted in the form of stool, what will happen? The blood will obviously turn blackish, or there will be certain discoloration. Whereas if the bleeding is from, please can you mute yourself, whoever it is? Thank you. But if the bleeding is from the lower GIT, usually the stool will have, they will be bleeding and the blood will be fresh because it is coming from the lower GIT. The distance is not much. There is not much alteration of the blood. But if the blood is coming from upper GIT, there will be alteration in the color and the blood will be changed into, say, blackish color. And when it is mixed with stool, it will give a color of blackish stool or so. So we have a case of melena, and as Dr. Hassan said, that this is a case of passage of black stool through the stool. So if it is black stool, what kind of bleeding is that? Is this upper GIT bleeding or lower GIT?
Upper
Upper
GI.
GI.
bleeding.
It is a case of upper GIT bleeding because it has altered color. By the time it reaches into the rectum and it is passed out as a stool, there will be alteration of color. So this is a case of melena, is a case of upper GIT bleeding. Can you give me some examples of lower GIT bleeding?
Ulcer. Anal fissures,
Piles.
hemorrhoid,
Yes,
Piles.
exactly.
and ulcer.
Yes.
Meckel's diverticulum.
Yes, Meckel's diverticulum, anal fissure, hemorrhoids is the commonest example where we'll find fresh blood. Okay, so this is done. So we came to know the girl is having some problem in the upper GIT. Okay, so we know the pathology from seeing melena. We understood that she is having a pathology in the upper part of the gastrointestinal tract, probably in the upper part of the small intestine. Now let us go back to our case. So we have the melena, which is signifying that this is a case of upper GIT, maybe the proximal part of this is duodenum or proximal part of the jejunum. Next is her mother says that she has a type of tummy pain in the morning, and this kind of tummy pain usually it is better when she has eaten. So what kind of tummy pain usually gets better when you eat?
This is
Ulcer.
ulcer.
Yes,
Gastric
ulcer.
ulcer.
What kind of ulcer?
Gastric ulcers.
Duodenal.
Yes, duodenal ulcer. So there is two type of
Duodenal.
peptic ulcer disease. One is gastric, one is duodenal ulcer. So this is a feature. Usually they will have tummy pain in the morning or pain at night. Even pain at night is a very important feature of peptic ulcer disease. Okay. So what kind of peptic ulcer disease? Usually if it is gastric ulcer disease, there are two type of peptic ulcer as I said. Gastric ulcer usually it worsens when you take the food. But duodenal ulcer, you will have the pain, but it resolves when you take the food. So they are saying that she is getting better when she has eaten. So she will have pain in the morning and she gets better when she eats. So this is a case of peptic ulcer disease, or say duodenal ulcer to be very specific. Okay, this is our second second clue. Now, she fractured her leg 2 weeks ago and then she fell down the stairs. Okay, there was a history of fracture. Now her leg is in the plaster cast and now she has been taking certain medications to help with the pain. So what is this? What could be the medication?
NSAIDs.
NSAID. NSAIDs are the commonest medication that you will be given. Painkillers along with you may be given a paracetamol, but commonly you'll be given NSAID if you have a fracture or if you have any kind of pain. Okay. Now we have three clues. Now you can correlate since you have three clues, that is she is having problem in the upper GIT, and now from the upper GIT there is a history of peptic ulcer disease. After that she is also getting NSAID. So you understood this girl is having peptic ulcer disease. Okay, that is the reason she's showing with these symptoms. Now what is the cause of a melena? Okay, everybody, peptic ulcer disease is very common, but when will you have a melena in peptic ulcer disease? Whenever peptic ulcer disease, whenever that is, it either it can lead to perforation or it is leading to bleeding peptic ulcer disease. Now, what are the causes of this bleeding in peptic ulcer disease? There are so many triggering factors. One of the most important triggering factor is a NSAID. So what is the role of NSAID? How does NSAID cause bleeding in peptic ulcer?
Causes platelet dysfunction.
Platelet dysfunction? Okay, I'm not aware of that. Maybe this is a,
Prostaglandin inhibition.
yes. So what happens is that the NSAID, it does a very specific thing. Most of the NSAID are COX inhibitor. Some are very specific COX-1 or COX-2. Some are non-specific COX inhibitor. So NSAID will inhibit the COX. When they inhibit the COX, what happens? Prostaglandins will be inhibited. Which prostaglandins? There are certain prostaglandins that are responsible for protecting the gastric mucosa against the acidic action. So, protection of the gastric mucosa. When you are giving NSAID to the patient, what will happen? The COX will be, there are COX-1 inhibitor, usually COX-1. This will be inhibited. As the result, prostaglandin will be reduced. As the result, the protective action of prostaglandin against for the stomach mucosa, against the acid in the stomach will not work. That is, the protective function will be lost. As a result, the stomach will be more prone to ulceration. First one is this. Second one, already if there is an existing ulcer, now there is more coming, hydrochloric acid is coming, and there is no protective function. Plus, it is going to lead to triggering of the ulcer. When the ulcer is triggered, that is, what will happen when an ulcer is triggered? What is the ulcer basically?
Exposed mucosa.
Sorry?
Exposed.
Yes. So whenever there is, basically what is it is, there will be some dysfunction in the mucosa, erosion of the mucosa. Okay. So when the mucosa is irritated, what will happen? The mucosal cells are very irritated. It will lead to bleeding. So what is happening? The NSAID are causing decrease in the prostaglandin, and due to decrease in the prostaglandin, that will lead to bleeding. And because it is bleeding, then what is it is a clinical feature, what it is showing as melena. So this is the reason that this child who was having peptic ulcer disease, and then after that after having peptic ulcer disease, she was taking some NSAID for the fracture. Now she is coming with melena. So this is how you can correlate. Let us go back to the question and see. So you have, this is 16-month-old girl having melena. So that is showing upper GIT problems, having PUD because there is morning pain and is relieving when she has eaten. Third one is that the history of taking medicine. So by these 3 clues, we can find out that this is a case of peptic ulcer disease, which has been precipitated by using NSAID and has led to melena. Okay. So this, as you can see clearly that in this question, they have not mentioned it is the case of peptic ulcer disease, or they have not mentioned to you that this is a case where NSAID was used. But how to make out? From the clues given. From the clues given, you have to make out the answer. So as you know, the FOP exam, that is Foundation of Practice, it is basically all clinical questions. By clinical question, it does not mean that they're going to ask you directly about what are the clinical features of peptic ulcer disease or what is the investigation. No, they're going to twist the question. See, in this question, they did not mention to you PUD, they did not mention to you NSAID. They will give you clues, and from the clues you have to make out this is a case of peptic ulcer disease, and she was given medication that has led to melena. See, even the medication, they did not even mention it was a case of NSAID. But you must have an idea that NSAID is the commonest drug that is given if a patient comes with fracture or any kind of pain. Okay, so we understood this is a case of peptic ulcer disease and it is leading to melena. Now, what is your choice of investigation in peptic ulcer disease? From the options given, this is an EMQ. We have to choose the option. What is your choice of investigation?
Endoscopy.
Endoscopy.
Stool culture.
Yes. Usually we'll do upper GIT endoscopy. That is our choice of investigation. So our first answer is upper GI, sorry, not this, endoscopy. D. Okay.
Don't we do go for stool examination for H. pylori in peptic ulcer disease?
Yes, we do go for it. We go for stool examination to see the antigen, and we go for Helicobacter urea breath test as well. But these are not mentioned here. And very specifically, even if you go for this, very specific, the confirmatory diagnosis, that is investigation, which is going to give you confirmatory diagnosis, is the endoscopy.
Yeah, direct visualization.
Yes. And thing is, whenever you have any clues in the exam, like you have any question in the exam, you have to think about certain differential diagnosis. In this case, you are thinking, okay, the investigation of choice, maybe you're doing the stool examination, you're doing urea breath test, you're doing endoscopy. But depending on which one is there in this options, depending on that as well, you have to choose. Okay.
Okay.
Now let us move to our next question. What do we have? Everybody is clear with the first one?
Yes.
Um, Dr. Fatima,
Yes, yes.
Yes. Yes.
why does the pain improves on eating in duodenal ulcer and opposite in gastric?
This one I'm not sure of this answer here, but I just know that in usually this is
Okay.
the way you can differentiate clinically as well.
Yeah, I think it has a relationship with the acid.
With the acid?
So when we eat something, it increases gastric production. So with eating, it worsen.
Okay. That's a very good explanation. Yes, that is possible. Thank you. Okay, let us move to next question. One is a 14-month-old presents with a 10-hour history of screaming. Now she is having non-bilious vomiting and has passed a red mucus stool. She is normally fit and well, though had a cough and cold in the last week. So history of upper respiratory tract infection. On examination, she is alert. She's pink, well perfused, but she's lethargic. Her abdomen is soft and tender with a mass in the right upper quadrant. Okay. So you have this girl who is a child who is 14-month-old. Okay, these are the clues. I'll write the clues for you. 14-month-old and having some non-bilious vomiting, and there is some passage of red mucus stool, and there is the abdomen is soft and tender, non-tender, and there is a mass in the right upper quadrant. What do you think is the clinical is a diagnosis here, or give me some differential diagnosis?
Intussusception.
Intussusception.
Okay, tell me how will you, what is the first clue here you will look in case of all cases of GIT? I think we discussed this in the last class.
Red mucus stool and screaming 10 hours.
Non-bilious vomiting
Non-bilious vomiting, age.
and mass in RF.
Mass in the right upper quadrant.
Yes. So what happens is that whenever you have a cause, even why is this not a case of gastroenteritis? Why this is not a case of gastroenteritis? What clues we have here?
In gastroenteritis, there is no mass.
Yes, first of all, there will be no mass, and usually in gastroenteritis, normal gastroenteritis, it
Loose
is caused by
stools
E.
will be there.
coli, loose stool, not bloody stool. They said there was a red mucus stool. Okay. Second thing is that the age of the child. This age of the child, and child is screaming, so that means he is having some abdominal pain, although it is non-tender. Okay, it is not tender, but there is abdominal pain and there is some non-bilious vomiting. Whenever there is bilious vomiting, usually in intussusception, what happens? Okay, when do we get bilious vomiting? When do we get non-bilious vomiting?
When
And
there
in the
is
same obstruction,
Yes. So
bilious
normally,
vomiting happens.
yes, if the obstruction is above the junction of the duodenum, that is bile duct and proximal ampulla of Vater will be closed. In those cases, we'll find all non-bilious vomiting. But if the obstruction is below the duodenum, in that case, ampulla of Vater of duodenum, in that case, usually we'll find bilious vomiting. So this is a case of non-bilious vomiting, which is showing us that obstruction is could be upper or lower. But this is the case of, also we are saying, depending on the age and the history, this is the case of intussusception. So why not bilious vomiting? If it is intussusception, most likely the obstruction is in the lower part of the GIT. So why not non-bilious? What happens is that in case of intussusception, initially the patient will come with non-bilious vomiting. Later on, the patient is going to develop bilious vomiting. Okay. So that is the reason. So this is a case of vomiting, 14-month-old child with abdominal pain, vomiting. There is a passage of red mucus stool. What is the other name? Pathognomic feature. This is a pathognomic feature for intussusception. It is, what is the other
Currant
name?
jelly.
Yes. This is the case of red currant jelly stool, which is a pathognomic feature of intussusception. And then had a cough. It does not have any kind of significance here. And then there is a mass in the right upper quadrant. Usually, what is this mass called?
sausage shape, ma'am.
This is usually called
Sausage shape, yes.
sausage. Yes, this is called sausage-shaped mass.
Appearance.
Sausage-shaped mass. So this is a case of intussusception. Please mute yourself if you're not speaking. This is a case of intussusception. Usually intussusception will present around the age of 18 months to 24 months. So age is an important point. There will be vomiting, abdominal pain, presence of red currant jelly stool, and there will be a history of, there will be on examination a sausage-shaped mass on the right side of the abdomen. There is another mass seen which is known as olive-shaped mass. What is that condition?
Pyloric stenosis.
Yes.
Pyloric stenosis.
So olive, this is sausage-shaped mass is seen in intussusception, and olive-shaped mass is usually seen in pyloric stenosis. So, okay, we understood this is the case of intussusception. And so what is the diagnosis you'll go for in intussusception? How will you diagnose?
Abdominal ultrasound.
Yes.
Ultrasound scan.
Abdomen will show signs of intestinal obstruction, and then it's a paraoperative finding.
Yes. First of all, so the choice of investigation, if we are suspecting it is a case of intussusception, is that we'll go for abdominal ultrasound. This is a case of intussusception, so the choice of investigation is abdominal ultrasound. Okay. Now, what are the findings we'll get in abdominal ultrasound? They usually call it, yes, target sign, or known as donut sign. Target sign is like this.
Shoulder sign.
Okay, okay. Thank you. So this is usually called target sign or a donut sign. We are going to find this in case of intussusception. And this is the choice of investigation in intussusception. Okay. So we have to match the scenario with the investigations given here. Okay. All right. Any doubts? Anybody has any doubts in this case?
Yeah, Dr. Fatima, here the child is otherwise alert and pink and perfused. But why they are writing lethargic? If she is alert, I don't understand how come she's lethargic.
Alert. She's alert and well perfused. That means she has not been into, she's not in shock. She's not in shock. But child is lethargic because child is having pain. There is vomiting. Look at this vomiting and has passed a red mucus stool. So obviously this is a stressful situation. That's why child is feeling lethargic. But they are excluding here the chances of shock. By that, they are saying that pink, well perfused and lethargic. No, but lethargic.
So it means it's like a acute, like an early stage of intussusception.
Yeah, all intussusceptions will not lead to shock. Intussusception can lead to shock. It can lead to enterocolitis. It can lead to a lot of things. Mostly patient can present with shock, but this is not a case of shock because patient is lethargic. Even if they say, in this case, if this was a case of shock, what is one thing that they would mention and you would be like, okay, this is shock?
CRT or something.
Yes, CRT.
Perfusion.
Yes, if they say the CRT is more than 3 seconds, you would consider this is a case of shock. Otherwise, just by saying that the child is sick, lethargic, that does not prove shock. Okay.
Also, until and unless intussusception is not complicated by perforation or gut gangrene, the child might not be in shock.
Yes, it is very only in some cases. Usually, intussusception will present like that. Sometimes it can present with enterocolitis or shock, but not always. Okay, thank you. So now clear with this?
Yes.
Yes.
Okay. Now let us move. Okay, just a minute. Okay, next one is a 15-month-old boy. Okay, the age is 15 months. Then after his father found nappy full of bright red stool. Okay, his father says he has been well, playing normally all day and has no past medical history of note. On assessment, he is pale. His capillary refill time is 4 seconds and heart rate is 180. Heart rate is increased, CRT increased, respiratory rate is 40. per minute, and then oxygen saturation 94% in air, blood pressure 70 by 45 millimeter of mercury, chest is clear, heart sounds normal, pulse is weak, abdomen is soft and non-tender with no palpable masses. So first of all, the age is a 15-month-old. So we studied if it is a case of upper GIT bleeding, it will present as alteration of the blood. The stool is going to have altered color. But if it is a case of lower GIT bleeding, usually they will present as fresh blood. So this is a case of, they found the nappy full of bright red color. So this is the case of,
Lower GI bleeding.
this is a case of lower GI bleeding. So we understood, okay, this is a case of lower GI bleeding. They said that, see, his abdomen is soft, non-tender, no palpable mass. He is playing well and everything is okay, but he's pale. Also, he is having increased CRT. That means child is going into shock. That means you can say this child is having, this 15-month-old child, this is a case of kind of he's having like a painless bleeding from somewhere is going on, like we are suspecting maybe from the lower GIT, and due to the loss of blood he has turned pale and also he is going into shock, but there is no other findings to be, like abdominal findings are absolutely normal. So what are the causes of painless abdominal, painless rectal bleeding, especially in this age?
Meckel diverticulum.
Diverticulum.
Yes, this is the case of Meckel's diverticulum. So usually what is Meckel's diverticulum? Meckel's diverticulum, what happens is that in case of in the fetal life, we have certain structures that disappears after birth. Like even in the heart, we have foramen ovale, ductus arteriosus, ductus venosus. So in the GIT, we have a diverticulum, a duct known as vitellointestinal duct. Okay, and that is supposed to disappear after birth, and this particular duct, actually, let me show you a picture from my class. Did we study Meckel's diverticulum in last class, guys?
Yep, we have studied it.
Okay, then it is upwards.
It's down.
Yes. So this is a PDF from my classes, Meckel's diverticulum. See, it is a remnant of vitellointestinal duct. They'll usually present with painless rectal bleeding and low hemoglobin. That is why the child is presenting with paleness. May present as intussusception or signs of obstruction. See here, this is the Meckel's diverticulum, which is the remnant of vitellointestinal duct. So in this case, what do we do? In this case, our choice of investigation is technetium scan. Now, what does technetium scan do? What happens is that basically gastric cells are present. Since it is gastric cell, it is supposed to be present in the stomach only. But what happens, gastric cells, that is ectopic gastric cells, in this case we call it, are also present in the Meckel's diverticulum. So technetium scan, whenever we investigate through technetium scan, basically it's an isotope that is going to look for the gastric cells outside the stomach. So we use the technetium scan, which is an isotope, and it is going to find out that there is some gastric cells here. So whenever we find a gastric cell in the lower GIT, specifically in the lower part of the small intestine, it is likely that it is due to Meckel's diverticulum, because in this diverticulum, usually we'll find gastric cells. So what is the choice of investigation in case of Meckel's diverticulum? Is technetium scan. Okay. Now let us go back. So in this case, as you can see, they did not mention that this is the case of Meckel's diverticulum. And okay, tell me, why not hemorrhoids here? How do we know it's not hemorrhoids? It could be, okay, hemorrhoids. That's why he's having lots
Painful
of...
bleeding.
Yeah.
Yes, one more
And
important thing.
something coming out from the anus. It must be there.
Another thing is that there would be an important history. The child has constipation,
There
right?
should not be delayed capillary refill, or
Yes,
it should
usually.
not be shock.
Yes, it will be very long history, and usually capillary refill time, it will not be very high. In hemorrhoids, don't present this critically. So this is not a case of hemorrhoids. Okay, what else? Could it be a case of, say, anal fissure?
It would be very painful.
Yes,
No,
again, it will be
it's
very painful. But
And
they
there will be
said,
history of constipation.
yes, there will be history of constipation as well. But this child, he is otherwise well. That means there is no constipation, no pain. He's just having painless bleeding. So painless bleeding along with, at this age, usually Meckel's diverticulum will present around 2 years of age. For example, sometimes they say 16 months to 2 years of age. So this is around 15 months. So you remember, for Meckel's diverticulum as well as for intussusception, usually they present around 15-16 months to 2 years of age. So we conclude this is the case of Meckel's diverticulum. So what is our choice of investigation here?
Technicians.
So we are going to do technetium scan. Okay, so we are done with this. Next, let us move to our next question. A 2-month-old breastfed boy presents with a long history of crying after feeds. Okay, he's crying only after feed, being generally unsettled with loose stool. He's 2-month-old with loose stool, crying after feed, which have been bloody on several occasions. He was born at 39.5 weeks following a normal pregnancy. Weight was 3.4 kg, which is normal. He has been breastfed from birth and has been prescribed sodium alginate by the GP for reflux disease. So he has been given an antacid. He has regular emollients for eczema. On examination, his weight is on 6.6 kg, which is between less than 25th centile. So weight is decreasing. See, before it was 25th to 50th centile. Now less than 25th centile, 9th to 25th centile. That means weight has decreased a lot. He is alert and responsive, but he is very unsettled, or you can call it irritable. He is crying when you examine him. His heart rate is 130. Central capillary refill time is 2 seconds. And apart from some moderate eczema, systemic examination is otherwise normal. Are you guys having problem with this, all these markings?
no.
Okay,
No.
please let me know.
No.
So this is a case or 2-month-old baby who has been breastfed since his birth. Now he's presenting with crying after birth, irritable, unsettled. Along with that, there is loose stool, and on occasionally this loose stool converts into bloody stool. Also, there is decrease in the growth velocity. And one more important history is that he is having a history of eczema. So child who is on breastfeeding, plus he's a very young child, 2-month-old, irritable after feed means something is associated with the feeding pattern. Okay, if it was a case of GORD, that is gastroesophageal reflux disease, he would respond well with the sodium alginate, that is antacid given by his GP. Since they are saying that he is unsettled after feeding, so we are thinking that this is associated with feeding. But sodium alginate they have been given, but still he is not responding. So something else with the feeding. So loose stool, bloody stool, along with eczema, along with there is some poor growth. What is the differential diagnosis that come to your mind?
Milk allergy.
Allergy.
Cross-milk
Allergy.
protein intolerance.
Cow milk protein allergy.
Cow's milk allergy.
Okay, cow's milk protein allergy. Okay. In my mind, when I saw this question first time, I thought of GOR, but GOR is excluded because of sodium alginate. And in case of GOR, gastroesophageal reflux, there would be no retardation of growth.
Eczema.
Yeah, usually eczema will not be there, or the growth pattern would be normal. If there is GORD, the child will present with respiratory tract infection, poor growth, etc. Now he is presenting with poor growth, but he is also not responding to the medicine that is given for GORD. So this is out. Now this could be a case of cow's milk protein allergy, but they said that he has been exclusively breastfed from the birth. So how is it cow's milk protein allergy?
Mother might be taking the cow milk.
Exactly. So his mother must be taking some cow's milk or any substance, for example, cheese, butter made from cow's milk. That is the reason he is presenting with features of cow's milk protein allergy. This is the exact history. They will tell you that child becomes very unsettled, irritable, crying after feeding, will present with diarrhea, and diarrhea may be occasionally bloody diarrhea. Along with that, for sure there will be some history of allergy. Usually they will say the child has eczema or the family has a history of atopy in the family. There's a history of atopic eczema or atopy in the family. Now, there is a case you are thinking this is a case of cow's milk protein allergy. Now, what kind of cow's milk protein allergy? There are two types. One is IgE mediated. Another one is non-IgE mediated. Which one do you think it is?
GE mediated.
Okay. What
IgE
happens is that what happens is that the no IgE mediated, usually they will have all the features of anaphylaxis, but in a milder form, and they will usually present very early, from few minutes to few hours. They'll present very early with blood, with diarrhea, loose stool, along with the rashes in the face. Then there will be crying and abdominal pain, and very early. But non-IgE mediated cow's milk protein, usually they'll present very late. They'll not present very early. And one very important pathognomic feature is that non-IgE mediated cow's milk protein allergy, usually they will present with colitis. So whenever there is colitis, there will be definitely some bloody diarrhea. So if you have a child who is having diarrhea with irritability after feeding or unsettling behavior, and there is a history of eczema, you will think about cow's milk protein allergy. Yes, you are absolutely right. But which cow's milk protein? Is it IgE mediated or non-IgE? If it is
Non-IgE mediated.
yes, if it is IgE mediated, there will be usually presentation will be very early and no bloody stool. But if it is non-IgE mediated, in that case, the presentation will be, there will be a long history. See, this child is coming with a long history. Plus, there will be definitely history of bloody stool. That is, which is an important feature of colitis. So this is a case of non-IgE mediated cow's milk protein allergy. Now, what is the most appropriate first line investigation? What do we do if it is a case of cow's milk protein?
Trial of maternal diary prepared.
We can give two treatments. One is that either we can ask the mother, since he's been breastfeeding, okay, we can ask the mother to stop all the dairy products, taking all the dairy products or cow's milk for about 2 to 6 weeks. Okay. And then we are going to see if he is responding. Another thing, if he has not been breastfed, if he is taking infant formula, in that case, what we can give?
Can give hypoallergenic
Yes.
formula.
Yes,
Soya
we'll give a, exactly. We are going to give a trial of hypoallergic infant formula milk, or known as extensively hydrolyzed formula milk, or we can say amino acid formula milk, or we can give soya based milk. Usually soya based milk are given after the 6 months of age, and extensively hydrolyzed and amino acid are usually given less than 6 months of age. In exam, instead of this hypoallergenic infant formula, they usually say extensively hydrolyzed formula is given. Okay. Why not lower GI endoscopy? This is basically not a GIT problem. This is due to lower GIT. We would consider if there was no history of eczema. The eczema is changing the entire thing for us. If there was no history of eczema, we would think that, okay, there is some pathology in the GIT that is causing bleeding. This is not a case of GIT pathology. Okay. Next one is trial of maternal free diet. Yes, we are going to do this. This is because our baby is breastfeeding. He's not having any infant formula. So his source of cow's milk protein is from mother. So we will ask the mother to stop any kind of cow's milk she has been taking. Trial of ranitidine, usually it will be given if we are suspecting this is the case of GORD. But this is not a case of GORD. Why not a case of GORD? Because of the eczema, and there is some faltering of growth, and child has already been given sodium alginate. Ultrasound scan of the abdomen. By all this eczema and the fact that he has been breastfeeding with colitis, all these are pointing out to our diagnosis of cow's milk protein allergy. In this case, we do not need an ultrasound. For making the correct diagnosis, first of all, you must know which is the correct answer, but you must also know why we are not selecting the other options. You must have an idea. Maybe not 100%, but you should be able to know, okay, this is the answer, but these two, why are these not the answers? Okay. So we are done with this case, and whatever I have told you and some more information are written in all these explanations.
Excuse me, Dr. Fatima.
Yes.
Shouldn't we go do this extensively hydrolyzed milk formula? Because it said first line of investigation, first
Yeah.
line of treatment.
Do you have
First
that
line should
option
be that.
here?
Yeah, first line should be this hypoallergic infant formula. If it doesn't resolve with it, then we should go for amino acid
Yes.
formula milk, and then in the last we should go for maternal dietary free diet,
No,
dairy free.
see that is if the baby is taking formula milk. In our case, baby has been breastfed from birth. In that case, baby does not have any source of cow's milk formula. Why will you give? He is already happily breastfeeding. Why will you introduce the infant formula to him? Right? If he was on infant formula, then instead of the normal infant formula, we will introduce the extensively hydrolyzed amino acid formula. But if he is breastfeeding and he is okay with that, the only problem we are finding is that the cow's milk protein, then we'll try to eradicate the source of cow's milk protein. We'll not try to introduce infant formula.
Yeah. Okay. Thank you.
Okay. And
Yeah,
also look
got
at his age. He's like less than 6 months of age. So we should try to, have him breastfed at all times. So whatever I have said in this case, all the explanation, all the answers are, everything is explained in this, all these explanations. So whenever you are reading clinical cases, don't worry about solving. Okay. Don't worry about solving. You will learn this solving after you finish reading maybe 1 or 2 times. I myself learned after maybe third time after reading this, how to differentiate, how to keep a differential diagnosis in mind, how to point out the differences, how to point out the clues. So when you're reading for the first time, don't focus on solving these answers. Your focus should be, you want to know how to solve these answers. You don't want to learn all at once. So you must keep a very calm mind and always see everything is mentioned here. Always read the clinical cases very well. Okay. So we are done with this case. Now we can do, there are two cases. One is case number 46 we have done. One is case number 15 and another one is 37. Okay, let us go. If everybody is clear with the previous case.
Yes. Yes.
Yes.
Case number 50. Belly ache. So it is like 80. Yes. So we have this case number 15. This is also from the GIT, gastrointestinal system. The name of the case is belly ache. So let us see what is there in this case. First, we are going to read the case, and then don't worry about the questions. We are just going to read and see that what is happening in the case. So you are seeing patient in the pediatric gastroenterology outpatient clinic. Your first patient saw his GP 8 weeks ago and has the following referral letter. Please see Peter, a previously well 12-year-old boy. His mother is worried that he has a reduced appetite and he has been less energetic than usual. He admits to having abdominal pain for the past 6 weeks, describing an intermittent cramp-like pain in the lower abdomen. The pain is associated with nausea, but is generally relieved by defecation. His stool are looser than usual, but there is no blood or mucus. He denies any problems at home but did fall out with his best friend 2 months ago. On examination, he appears well. Abdomen is soft, no palpable mass, weight and height are growing along the 25th centile. So we have a referral letter with a boy, 12-year-old Peter, who has reduced appetite. There is abdominal pain. Along with abdominal pain, quite some time. He's saying the abdominal pain for 6 weeks. So it is like a chronic abdominal pain. Along with that, there is nausea, but abdomen is soft, no palpable mass. Stool is just loose, but stool is okay. And he will have the abdominal pain is usually relieved by defecation. And no other problem, no blood in the stool, no mucus in the stool. Growth is quite normal on the 25th centile. So this is a case of chronic abdominal pain. So before solving this case, let us move through other complete. Okay, tell me if this is a case of chronic abdominal pain, when there is a history of chronic abdominal pain, what are the differential diagnoses you have to keep in mind? What do you think this boy has?
IBD.
IBS.
IBS.
Celiac disease.
Okay, one is saying IBD, one is saying IBS. Okay, very good. You are having more idea.
Functional abdominal pain.
Okay, celiac disease. Another one is functional abdominal pain. These are
Abdominal
the
migraine.
abdominal migraine. Okay, these are the causes of chronic abdominal pain. Now, when you have these cases, you are thinking that, okay, this is a case of chronic abdominal pain, and you are having all these thoughts in mind that this could be the causes, this could be the differential diagnosis. Now you need to exclude one by one. First of all, before excluding, tell me the most important points from this case. What are the important things?
He has abdominal pain for 6 weeks, which
Reduced
actually
appetite.
started after he fell out with his best friend. However, it is not affecting his weight, height, or overall growth.
Okay.
And abdominal examination is insignificant.
Pain is relieved by defecation.
Yes.
Okay.
Pain
What does
is
that
relieved.
signify? That means it's not very much severe. They're saying pain is relieved by defecation. It's very common. It can happen due to, simple malabsorption, not chronic, or it can happen due to in everyday life if you're eating a lot or there is some change in your diet. Okay. Another important history is that he said no problems at home, but he had a history of falling out with his best friend. That means some breakup with his best friend. They're not talking or so for 2 months ago. So there is some stressful situation, emotionally stressful situation. Okay. And as one of the doctors said that he's growing well apart from this. So in case of IBS, what would be the scenario? What are the features of IBS?
Intermittent constipation and diarrhea history.
And what else?
There would be history of stress,
Alternating loose stools and
anxiety.
constipation. History of fever, arthritis.
Okay. So if it is a case of, yes, in case of IBS, there would be one important feature is that there would be history of diarrhea as well as constipation alternating. And in IBS, there will be severe abdominal pain. There will be, and yes, one history from here is matching with IBS, that is, it is relieved on defecation, right? But apart from that, IBS will have a very strong history of alternating diarrhea and constipation. That is not there. So we can say that, okay, this is not a case of IBS. Okay, we are throwing out IBS. What about IBD? What happens in inflammatory bowel disease?
Wouldn't there be a blood in stools?
Extraintestinal manifestations.
Yes, there would be a history of bloody diarrhea, or diarrhea is also possible in Crohn's disease. Bloody diarrhea is usually seen in ulcerative colitis. Usually that would hamper his growth. So he would have failure to thrive. His growth is quite normal. Okay, and there would be some extra intestinal features like arthritis would be there. And if it is a case of Crohn's disease, he would come with abdominal pain with anal tag, anal fissure, some conditions like that. There is no history of such. He just have loose stool. There is no bloody stool. His growth is very important. Growth is completely normal. So this is not a case of inflammatory bowel disease. Anybody else thinks this could be a case of inflammatory bowel disease? Inflammatory bowel disease, first of all, apart from the diarrhea or bloody diarrhea, there has to be a very important pathological feature that is going to hamper your growth. But the growth of this child is absolutely normal. So this is not inflammatory bowel disease. Why not celiac disease?
Celiac disease will also be
Failure to thrive.
Age.
present with
Yes.
hampering of growth, and the symptoms would not start right away at this age.
Okay.
There can be a longer history,
Iron
and there
deficiency
will be
example.
short stature as well.
Yes. So first of all, you're saying that celiac will not present at this age. There are two forms of celiac. Yes, celiac most likely presents around the age of 2 years, that is from 8 months to 2 years after weaning. But there are also other forms of celiac which can present later. This could be
Actually,
actually. Mhm.
I was trying to say that celiac with gastrointestinal symptoms appears earlier than
Okay.
the celiac that presents with the other constitutional symptoms.
Okay. Okay. Another important thing is that, as you guys said, there will be failure to thrive. Yes, there will be problem with the growth, poor growth, but see, he is having normal growth. Another one of the doctors said he'll have iron deficiency anemia. Now, why in celiac we have iron deficiency anemia? Now, in celiac, what is the basic pathology? Celiac disease is basically a hypersensitivity reaction, and this reaction takes place when the gluten, yes, against gluten in the duodenum, and this reaction takes place in the duodenum. Okay, against gluten there will be type 4 hypersensitivity reaction. This is also an important question in the recalls, that is celiac, the type example of type 4 hypersensitivity they will give you, celiac and contact dermatitis. Okay, now the celiac disease, the problem is in the duodenum. Whenever the problem is in the duodenum due to the celiac disease, what are the findings we'll get? There will be villus atrophy, crypt hypertrophy, and along with that, intraepithelial lymphocytosis. So that is going to lead us to, that means celiac disease is going to lead us to villus atrophy. And whenever there is villus atrophy, that means there will be less absorption. We know that iron is usually absorbed in the proximal part of the small intestine, likely in the duodenum. In the science of pediatrics, they have mentioned duodenum, but in clinical cases, they have mentioned both duodenum and jejunum. So we are considering the science of pediatrics book in the duodenum. So what happens? The iron is usually absorbed in the duodenum. Whenever there is celiac disease, the pathology will be in the duodenum. As a result, what will happen? The iron will not be absorbed. So patient will present to you with iron deficiency anemia. That is, patient is going to present to you with most likely paleness, right? Now, do you think this iron deficiency anemia can be present in inflammatory bowel disease as well?
Yes.
It can be present in which one? It can be present in case of Crohn's disease, because Crohn's disease usually it involves from the mouth GI to
anus.
yes, it is called the whole alimentary tract from the mouth to the anus. Okay, so it can include, but most likely what happens in Crohn's is that it involves the ileum. Although it involves all part of the gastrointestinal tract, but it involves mostly the ileum. But yes, it could be possible. It could be a case of Crohn's. Okay. Now, this could be okay. Iron deficiency anemia, you're telling that it is possible in both cases. Now, clinically, what will be the difference? In a case with celiac disease, there is one very important finding we'll find in case of a child with celiac disease. What is that? Children with celiac disease, they'll be very irritable. Second thing is that there will be always abdominal distension. In both celiac and Crohn's, you will have paleness, you will have failure to growth, you will have loose stool, diarrhea will be there. But in case of celiac, you will have abdominal distension. And as well as the child is usually very irritable. There is wasting of buttock muscle. There is a good picture also in the illustrated textbook of pediatrics. Okay. So this is all, these all are not present in this child. He does not have any abdominal distension, abdomen is soft, no palpable mass, no problem at all. Okay, so celiac is out. Now, what are the features of functional abdominal pain? Tell me. Are you guys there? Basically, functional abdominal pain means the child will have abdominal pain, which will be usually for a few weeks, that is chronically, but will not find any pathology. That is, there is no organic problem at all. But the child will definitely have some abdominal pain. And what will be the nature of the abdominal pain? What is the age? Usually what happens is that according to, let me just open this book and tell you with reference. There is important age of presentation of functional abdominal pain. Functional abdominal pain, usually it will present at 2 ages. One is it will present around 6 to 7 years of age, and then around, just a minute please. One is they're going to present around 6 to 7 years of age, and then they're going to present around 7 to 12 years of age. So this is usually the age of presentation around, that is 12 years. You say this is usually the age of presentation, 7 to 12 is for functional abdominal pain. Second thing is that what are the other things? The child will usually have episodic abdominal pain. There will be usually there will be nausea will be associated with it, but there is no inflammation. That is, and there is no evidence of fever. There is abdomen is completely normal on examination. The stool is completely abdomen. Bowel habits are completely normal. Occasionally, the child may have altered bowel, but on examination as well as on investigation, you will not find anything else. Everything will be normal. In this case, we will call that is a case of functional abdominal pain. Also, to prove it is a case of functional abdominal pain, the duration should be at least for 2 months. That is, the child should have this abdominal pain, which is having nausea, but normal growth. It is relieved by defecation. All these features at least for 2 months. Chronic history. Once every week for 2 months. If these all are fulfilling our criteria, then we call it this is a case of functional abdominal pain. Now, what do we have in the history that says this is a case of functional abdominal pain? Is it or not?
The abdominal examination is insignificant.
Sorry, normal examination. What else?
And
this is normal.
it's not faltering the growth.
Yes.
Followed out with
his best friend.
No
Pain is
faltering of growth. Then?
Pain is relieved by defecation.
Okay. Somebody else is also speaking. Can you tell again your point, please?
I said he had normal stool. No, there's no blood or mucus in the stool.
Yes, blood or mucus or stool, it is relieved by defecation. So by diagnosis of exclusion, we can say that this is a case of functional abdominal pain. Do you guys agree?
Yes.
So if this
Shouldn't
is the
it be
case,
for more than 2 months?
see, he came with a history of 8 weeks ago. And the first patient saw his GP for 8 weeks ago. 8 weeks means this is a case of 2 months.
Okay,
So the history is pretty long. Okay, and it has to be at least present once per week. The abdominal pain should be present once per week. Okay, so this is a case of functional abdominal pain. How we understood is that to understand it is a case of functional abdominal pain, you must be able to rule out or exclude all the other differential diagnosis. First point. Second thing is that there has to be certain criteria of functional abdominal pain. Okay. Third point is that you must know what are the red flags of chronic abdominal pain. that is, any child is coming to you with a chronic abdominal pain, you must know that what are the signs are red flags. Now we will study what are the red flags of chronic abdominal pain. What are the red flags if child is coming? One is if there is any weight loss, if there is any growth deceleration or weight loss, if there is any blood loss, GIT blood loss, maybe bloody stool, if there is any significant vomiting, not once or twice, significant vomiting, if there is chronic severe diarrhea, they said that stools are looser, but there is no blood or mucus, and it is relieved by defecation, the abdominal pain. It is not very severe. If there is persistent right-sided abdominal pain, if there is a family history of inflammatory bowel disease, if there is any unexplained fever, these are the points you have to remember. These are the red flags of chronic abdominal pain. Now, I said you to exclude it, to diagnose any child, first of all, you have to rule out all the differential diagnoses. We have done that here. We have to look for criteria of the functional abdominal pain. We have the criteria. Third one is you have to see if there is any red flags of the chronic abdominal pain. Do we have any of the red flags here?
No.
We do not have. So this is a case of, we are concluding this is a case of functional abdominal pain. So if this is a functional abdominal pain, what is the choice of investigation? Absolutely, it's functional. Means even if you investigate, you're not going to get any kind of findings. There is no organic pathology. There is no organic problem. So what is that you're going to find? What is the treatment you're going to give or investigation you're going to do?
Reassurance.
Yes.
Reassurance.
You'll go for reassurance because no treatment, no investigation is going to, no, it's not right to say no treatment. We do give treatment of analgesic, antispasmodic, or symptomatic treatment you have to give, because you cannot say the patient that, okay, this is nothing. Moreover, there is one very important history of this functional abdominal pain here. It's not related to the GIT. What is it? See, he had a fallout with his best friend 2 months ago. That means there is some emotionally stressful situation. Usually they will say the child's parents separated, or he was very close to his grandfather died, or he's having some problems of bullying in the school, he has some problems with the best friend. This is the commonest history they give in exam. So this is one important history, that is emotionally stressful situation. Our children usually, when they have exams approaching, they will always have this functional abdominal pain. So in this case, we are going to do reassurance, because even if we investigate, there will be no other problems identified. Why not an abdominal X-ray? What do we think abdominal X-ray can diagnose? If there is usually any kind of obstruction we are suspecting, in those cases we can go for an ultrasound or abdominal X-ray. What about anti-endomysial antibody or anti-tissue transglutaminase? When do we do this?
We advise them to
celiac.
give
Celiac, if we're not suspecting celiac disease.
Yes. In case of celiac, we would do this. We are not suspecting celiac. Urgent referral to a gastroenterologist. When we would urgently refer?
if there would be any red flags.
Yes.
When there are red flags.
Please mute yourself. Thank you. If there is any red flag signs, then we will refer the child to the gastroenterologist. So our answer is reassurance. Are we clear with this? See, up to here, we have learned the differential diagnosis. What are the pathognomic functions, features of the differential diagnosis, that is celiac, inflammatory bowel disease, and we saw that other features of functional abdominal pain. We learned what are the red flags. Okay. So now let's see what is happening. Since being seen by the GP, Dr. Priyanka, I have to mute you.
I have a question.
Since being seen by his GP, Peter tells you that he has continued to have the abdominal pain. So GP saw him 8 weeks ago, 2 months ago. Since that time now, still he is having the abdominal pain and diarrhea. The pain is now worse on defecation. It has changed its course. Before it was relieved by defecation, now it is worse on defecation. And he has noticed blood in his stool. So there is bloody stool. He has missed several days of school and has lost 2 kg weight. On examination, he is pale. Abdomen is tender on palpation. In the lower quadrants, there are no palpable mass. Anal fissure is identified on external anal inspection. So now he's presenting with abdominal pain, diarrhea, there is loss of weight, there is blood in his stool, the abdomen is tender, he is pale, there is anal fissure. So how many red flags do we have here? We have multiple red flags, right? This is multiple red flag. Even if you do not think about the diagnosis, any child is presenting to you with blood loss, that is GIT. Please tell red flag sign of persistent right side abdominal pain. Signify right-sided abdominal pain, specifically usually seen in case of Crohn's disease. Usually seen in case of Crohn's disease. If there is a blood, if there is diarrhea along with abdominal pain and pain in the right side of the abdomen, that usually signifies Crohn's disease. Dr. Priyanka, let us solve here, okay? We are discussing. Okay, so what is happening is that, so even if you do not reach the diagnosis, you have to think that this child is having bloody stool, there is a loss of weight, and he's having some anal fissure. So this is bloody stool, loss of weight, all these are important red flags. So what do you think? Child is presenting to you with abdominal pain, diarrhea, there is bloody stool, loss of weight, he's pale, abdomen is tender, but there is an anal fissure. What do you think is the differential diagnosis?
Crohn's disease.
Crohn's.
Okay, why not ulcerative colitis? He has bloody stool.
Because in Crohn's disease there is a fissures and stachures fistula occur.
Exactly. This is the case of Crohn's disease. That's why he has anal fissure. And due to the fissure, maybe he's having blood in the stool. He has noticed blood in stool. Maybe it's not very prominent. They did not say bloody stool. Maybe some amount of blood. So abdominal pain with diarrhea, which has been going chronically, with loss of weight. Along with that, there is some anal fissure. Another important thing is that he is becoming pale. So we said that in case of Crohn's disease, there could be iron deficiency anemia. Another thing is that in Crohn's disease, usually patient will come with tenderness or a mass in the right lower abdomen. And in case of ulcerative colitis, patient will come with tenderness or mass in the left lower abdomen. So this patient is coming with tenderness in the right lower abdomen. Okay, so this is a case of Crohn's disease. What other things can you keep in mind? Usually in case of Crohn's disease, the ESR, CRP, that is the inflammatory markers, even though they are very non-specific, they will be increased in all kind of disorders, all kind of inflammatory disorders. But if you compare Crohn's and ulcerative colitis, the ESR and CRP will be more raised in case of Crohn's disease as compared to ulcerative colitis. And there will be a history of mouth ulcers in Crohn's disease. There will be history of anal fissure in case of Crohn's disease. Okay. Now, which of the following? So our diagnosis here is this is a case of Crohn's disease. First, this child presented to us with only functional abdominal pain. Now he's presenting to us with Crohn's disease. So what is our investigation? Which of the following investigation is most likely to provide a definitive diagnosis? First one is barium meal. When do we do barium meal? If we suspect any kind of
obstruction or
obstruction.
stenosis.
Exactly. Any kind of
throughout the
obstruction,
path.
we'll go for barium meal. Is this a case of obstruction? No, this is not a case of obstruction. So this is out. Crohn's disease is not due to obstruction. City abdomen. City abdomen, actually, it can give us, it can say that, okay, there has been some issue, but if it is causing any obstruction or such, but it cannot identify the specific pathology. And in our case, we do not have any features of obstruction. So in this case, city abdomen is not going to give us any finding. Third thing is that endoscopic biopsy. So this is a case of Crohn's disease. They are saying that we will do endoscopic biopsy. Should we do endoscopic biopsy in case of Crohn's disease?
Yes.
Okay,
Yes.
we will do endoscopic biopsy. Why?
See
It will
that.
provide us with a definitive features that we
Exactly.
want to
We are
see.
we
if
want to
it's-
see
when it's definitive, biopsy is our choice.
Exactly. So if they say, they said here definitive diagnosis is endoscopic biopsy because this is a case of Crohn's disease. If it was case of ulcerative colitis, we would choose colonoscopic biopsy, right? What about ESR CRP? As I said, ESR CRP usually increases in Crohn's disease, but it also increases in other inflammatory disorders. So it is not very specific. It is not definitive. It could be used as a screening disorder, screening investigation. Sorry. Fecal calprotectin. So fecal calprotectin, even though it increases in inflammatory bowel disease, but you cannot differentiate between ulcerative colitis and Crohn's. It is very non-specific. So they are asking for, no, they are not asking for a case of screening disorder or screening investigation. They're asking to us about a definitive investigation. How can we reach a definitive diagnosis? So if they ask for definitive diagnosis, definitely if it is a case of Crohn's, we'll do endoscopic biopsy. If it is a case of ulcerative colitis, we'll do colonoscopic biopsy. Are we clear here? Everybody is clear? Okay. Next is, you discuss with the consultant in the clinic who commences Peter on glucocorticoids. So this is a case of Crohn's disease. We are treating the patient with glucocorticoid. However, on review, it is noted that his growth is poor, okay, and he is experiencing unpleasant side effect. The steroids are stopped. What would be your first line alternative treatment to induce remission? So in Crohn's disease, the first line treatment you give is prednisolone or you give glucocorticoid. But if the patient, there is no remission, you're not able to obtain remission, patient is having continuous relapse or patient is experiencing any kind of side effects, in that case, you can go for enteral nutrition for 2 to 6 weeks. So first start with steroid. If patient is not responding or patient is having some adverse effects due to this, he is having poor growth and they're saying that he's experiencing unpleasant side effect. In that case, you can go for enteral nutrition. Even after that, patient does not respond, then you can go for methotrexate, infliximab, you can go for 5-aminosalicylic acid, azathioprine and all that. Okay. So this is our case about the first, it was diagnosed as functional abdominal pain. Then we found out it is a case of Crohn's disease and what are the investigation we'll do and what is the treatment we give and what is the treatment we have to give if in case the first line treatment is not working out. Are we clear with this?
Yes.
Okay. So whatever I said is actually here in all the, in this case here, see these are the red flag or alarm symptoms that are associated with chronic abdominal pain. So any child comes to us with chronic abdominal pain, we have to make sure that the red flags are present or not. If there is red flags, we have to proceed towards investigation. Everything whatever I have told here is mentioned. And these are the commonest causes of chronic abdominal pain. Okay. So this was about the inflammatory bowel disease and this was one of the cases. Now let us move on to our next case. It is already more than 1 hour. Okay, next case. Next case is case number 37 and case number 50. We'll go to 37. Let's see. I think case number 36 is a case of hepato case. Since we have not studied hepato in class, so I didn't want to take that. Five. Okay, 37. So this case number 37, they are saying that the history helps. Okay, so we have Jill, a 7-month-old girl She's a 7-month-old baby. Presents to her GP with difficulty in passing stool. Her mother describes her as not opening bowels for 4 to 5 days at a time, and when she does, passes a large solid stool, which is painful for her. So that means this 7-month-old girl is having constipation. She was breastfed until 6 months of age and has only ever opened her bowel 2 to 3 times each week and vomits frequently. Okay. She appears to be in discomfort when passing stool. That means it is a case of constipation. On examination, her abdomen is soft, non-tender, with a palpable mass in the left iliac fossa. Okay. She has normal bowel sounds. So we said that just a while ago. I think somebody asked that what are the differential diagnosis of a mass in the left iliac fossa. In the left, if it is in the right iliac fossa, it is usually along with the diarrhea, there is failure to thrive and all that. It is usually due to, right on the right side, if there is any mass, it's due to Crohn's. On the left side is due to ulcerative colitis. Now look at the age of the child. Usually ulcerative colitis will present in older age, older children, not in this very young child. This is just 7-month infant. So we have a 7-month-old infant. She is having constipation. Also, she frequently vomits. There is some discomfort and she is having a mass in the left iliac fossa. But she has normal bowel sounds. What could be the differential diagnosis we'll keep in mind?
Hirschsprung
It could be Hirschsprung disease.
Okay. It could be constipation. Just a case of simple constipation. Why are you calling it? Why are you calling it Hirschsprung disease? For to know that it is a case of Hirschsprung disease, what important history you must know?
When the baby passes his early stool.
delayed
passage of meconium more than 48 hours.
Yes, there should be history of delayed passage of meconium. This baby is not saying anything like that. And if we are thinking, we have to keep differential diagnosis in mind at first. Without a proper hypothyroidism. Okay, if she was a case of hypothyroidism, what other history we would receive?
Floppy child.
The milestone, hypotonia, and
Failure to
prolonged
thrive,
Jaundice, swelling,
jaundice
umbilical
history. Yes,
Umbilical hernia.
yes, jaundice, umbilical hernia. There would be failure to thrive. All this history we would receive. There is no other no history like that. Okay. So this could be our differential diagnosis. Could be this is a case of either constipation, just a simple case, or a case of Hirschsprung. To prove it is a case of Hirschsprung, we do not have a very important piece of information. There is delayed passage of meconium. Okay. So we have these two differential diagnoses. What is the cause of this mass in her left iliac fossa? What do you think?
Fecal impaction.
Yes. Since she is having constipation and they said that she is having real problem in defecating and she appears to be in discomfort when passing stool, this is the case of impaction, fecal impaction, and as a result, we feel a mass in the left iliac fossa. Okay. Now, when imaging a child with idiopathic chronic constipation who is impacted in this child, which of the following is the best first management step? That is, what are you going to do? If a child comes to you with impaction, fecal impaction, constipation, what is the first treatment you will do? We studied in our last class.
Check the hydration status and rehydrate and dietary advice. These are the two main things.
Okay.
Movicol.
Yes, you're going to give Movicol or Macrogol, but how are you going to give?
You'll start with the low dose and then increase to the maximum dose by in 1 week.
Exactly. So whenever a child comes to us, see, Dr. Hassan, if child comes to us with only constipation, with impaction, first our main duty is to treat the impaction. We'll give the fluid, we'll give the dietary, all the advices later. First, our duty is that we have to release this impaction. So for that, we have to give Movicol or Macrogol. How we'll give? We'll give this, usually we'll start with the lowest dose and we'll start increasing the dose according to the response for 1 week. After 1 week, we are going to review the child. Okay. If then also child is not responding, this was for oral impaction, then we'll go for rectal impaction, this impaction. Okay, we are going to give enema. If after going for rectal disinfection, child is not responding, then we will go for manual disinfection.
Yes.
And manual disinfection has to be done by a specialist. So this our child has come, she is having some infection, we have to disinfect her, and constipation. So what is the first treatment we are going to give? We have to give macrogol disinfection regime, which starting with the low dose and increasing according to response. I think we did this in the last class, and we did this from
Yes.
the guidelines. Okay, after, okay, you are giving this and child is responding. Now you're going to discharge the child. While discharging, you have to give some maintenance dose for about 4 to 6 months. You have to give regular macrogol laxative. Along with that, you will say that you have to drink a lot of water, dietary management and all that. But first is that your child is coming with infection, you have to release that. Okay. So in our case, we are going for this. Dietary advice or regular lactulose, these all will be later.
I have a question.
Yes.
Why are we starting with low dose and gradually increasing the dose?
Because we want to see, that is for any drug, you start with the lowest dose. If the patient is responding at low dose, then it's okay. You will continue with that dose itself. If the patient is not responding, then gradually you'll start increasing the dose, depending on the response.
Okay.
Okay. For any drug, I think we do that. For everything, usually we'll start with the lowest dose possible. If patient is not responding, then we'll increase the dose. Okay. Next is, so we are going to give a macrogol disinfection. Also, it is known as Movicol. We'll start with the low and then increase up to 1 week. Now, this patient, now she returns 1 month later and her symptoms are remaining, same constipation. On occasion, there has been bright red blood in her nappy. Following passing a stool, at this visit, Jill's mother has brought her red book, which is the child health record, with her. The records that at birth, Jill weighed 3.5 kg, which is on the 50th centile good. And when weighed last week, she was on the 9th centile. So there is some failure of growth, failure to thrive. Her newborn examination is demonstrated by clicky right hip, but nil S. Okay, there was some problem in the hip. She was discharged at 12 hours of age, and the midwife checked at home record that she passed meconium for the first time on day 3 of life. Examination were same as the previous. However, external inspection, a small anal fissure is noted. So what do we have here? We saw her after 1 month. She is coming to us. We have disinfected her. Now still she's coming with the same symptoms of constipation. Okay, constipation, same symptoms. Along with that, we saw her growth, which is showing failure to thrive. So third thing is that there was a history of delayed passage of meconium. Now your differential diagnosis of Hirschsprung can be used here. Because chronic constipation with delayed passage of meconium, it is a case of Hirschsprung disease. What is the pathology in Hirschsprung disease?
Absence of the ganglionic fibers in the crown.
Cells in the mesenteric flexures or the submucosa, usually absence of ganglionic cells. So usually what happens in Hirschsprung disease, let me show you.
There is absence of plexus in mesenteric plexus and submucosal plexus. And the part where the plexus is absent is continuously contracted.
Yes.
And feces will collect in the proximal colon, which will get dilated.
Yes, very good. Very good. So see this absence of mesenteric and Meissner's plexures, which is also, these are also known as the submucosal plexures because they are present in the submucosa and in the submucous layer of the large intestine, and this portion lacks any kind of innervation. As a result, they cannot dilate. So this portion of the intestine will remain contracted and they will create features of an obstruction. As she said, the feces will come and disimpact here. So this is the main pathology in Hirschsprung disease, and this is a portion that is frequently asked in the recalls. That is, what is the pathology in Hirschsprung disease? So patient is coming to you with Hirschsprung disease. It is commonly found in case of males. It is more common in males and it is frequently associated with patients with Down syndrome. Okay. What happens? Usually there will be failure of passage of meconium in the first 24 hours of life, which is a red flag for constipation. So in this patient also they can develop vomiting, usually bile stain vomiting. Look at this portion of, this is a normal portion of the intestine, and look at this portion. This is constricted. So this case of Hirschsprung disease, now what is the investigation we should be doing?
Rectal biopsy.
Yes,
Rectal
we'll do
biopsy.
rectal biopsy. Why? Because this portion, since this portion is contracted, the pathology is in this portion, we'll do a biopsy and then we'll see if there is any presence of the mesenteric and Meissner's plexus in the submucous layer. So we are seeing the histological slide. We have to see the histological pathology. Okay, we are seeing going to see the main pathology. So we'll do a rectal biopsy. What is the most concerning sign and symptom of a presentation? So they are saying from the presentation she has given, abdominal mass, anal fissure, blood per rectum, failure to pass meconium, faltering of growth. Which one is very important? Which one you should be concerned about?
Failure to
Faltering
pass.
of growth.
Failure to pass
Failure to pass
meconium.
meconium is an important feature that we have to be concerned about. What diagnostic investigation will we do? We'll do a rectal biopsy in case of Hirschsprung disease. And
Dr. Fatma, why anal fissure or filtering growth is not a concerning feature? Most concerning feature, why we have to put this
see,
failure?
okay. See, anal fissure, first of all, anal fissure can occur in any normal individual with constipation, right? Okay. Second thing is that failure of growth, faltering of growth is an important thing. Obviously, it is associated with all kind of chronic disorder. But if there is faltering, if any patient comes to you with faltering of growth, you will not have one diagnosis. You will have at least 2 to 3 differential diagnoses. But if they say failure to pass meconium, that is very pathognomic and very definitive. They're asking for the most concerning and most definitive feature.
For the diagnosis.
For the diagnosis in
Okay,
her
okay. Now I got
presentation. So in this case, this is a case of Hirschsprung disease.
Yeah, sure.
Okay. So this was a case of Hirschsprung disease, very, very easy case. And then all the explanation is given here. I think this is the easiest case of GIT. Whenever a child comes to you.
Thanks to you, it's easiest.
Oh, thank you. It will be easy for anybody. Like, you just read, don't be concerned about that, how to solve this. I'm just solving this just to show you. I have read this explanation a few times. And I think until my first batch, I'm taking my second regular batch. Until my first batch, before every class, I would read the clinical cases. So I have read the clinical cases about more than 3 to 4 times. More than 4 times. So you have to read, and trust me, it will never, it will never be a waste. Even for AKP, even if you're not going for MRCPCH exam at all, but to see a case and look for the history, and it is like a case presentation, a complete case presentation. You get to learn in depth a lot of things.
Yeah.
So we'll end the class today. I think we have done 3 cases, yes?
Yes.
Okay. So we'll end the class today. Please give your feedback. How can I join your session? Please message me on WhatsApp, please. I'll reply to you for my sessions. Okay. Please give your feedback about the class, and this was class on GIT. I think next you guys can suggest me. I think I have asked some people to suggest even, none of them were interested. They did not suggest, they were too lazy. So yeah, so they were too lazy. Please suggest me, even the doctors in my batch, please suggest me whatever cases you find difficult, then we'll have a discussion session. It will be really good. We have done, what is your WhatsApp number, please? Okay, do you follow my, please do classes on recalls? Yes, I will do a free class on recalls, and I do have a paid batch, so I feel like doing all the classes free, it's not very much fair to the ones who are paying. So, but I'll do one class on recall for free. My WhatsApp number, if you follow my YouTube channel, or if you follow my Facebook page, then I can give you. Just a minute. Let me just message. Okay. Genetic inheritance. Okay, we had a very good class recently on
Yeah,
genetics.
Yeah.
it was
Yeah, it was very good.
Yes, Alhamdulillah, it was very good, and it is like a very genetic inheritance. Yes, I will do a class. Maybe it will take some time. I will do a class on genetic inheritance. I personally enjoy genetics a lot, so I will do a class and recalls as well. And somebody, just a minute, I'm interested in genetics. Okay. Okay, maybe next time we'll do. Thank you so much for the feedback. If you really like my class, please, you can give the feedback on Facebook page or my Facebook group, or you can contact me on WhatsApp. Thank you, everyone. And do let me know if you want me to solve any classes. And for the doctors in my group, please let me know. Let me know what are the cases you want to see, because I will not be teaching all the cases in class. Okay, you have to let me know if you find any cases difficult. We'll have a discussion session and we'll do it separately and it will be easier. Recordings available for genetics. Yeah, it is only for my for my classes, those who have enrolled in my class. Okay, we'll do the genetics class maybe some other day. Thank you, everyone. I'll end the class, and this recording will be available on YouTube.